Hello everyone, welcome to your online lecture for the hip and the pelvis. I'm Dr. Cosby. We're going to start always with the anatomy. I believe anatomy is extremely important and really serves as kind of the foundation for everything that we do as clinicians. So first we're going to start with the bony anatomy. On the right hand side we'll see an image which represents really the articulation between the hip joint and the pelvis. We'll call this the hip joint. And then on the left hand side what we're really going to be focused in on is pelvis anatomy. But let's start over here on the right hand side. This anatomical structure is known as the femur, largest bone in the body, right? So we have the femur, which as we move more proximally will have a very large kind of lateral projection known as the greater trochanter. If you lay on one side and your hip is facing the ceiling, you probably could do a downward swipe and you'd feel a bony projection. That is your greater trochanter. That greater trochanter kind of curves to become the femoral neck, and so this is a place where the bone is changing its shape. So what do you automatically think might happen very often at this point or juncture point of the femur, right? Most often fracture, right? Because the bone is changing its shape, so it's where it's at its weakest. And then as we continue on, it rounds out and becomes what we call is the femoral head. And so it's the femoral head that articulates with the pelvis itself. It articulates with the pelvis via the acetabulum. So if we look at it from a pelvis perspective, we have the ilium, and as we travel distally, we can see this bony kind of projection here known as the acetabulum. We remove the hip from its insertion space. What we can see right in here is that the acetabulum is going to be deep enough to receive that rounded femoral head, right? And so in the acetabulum, we have an acetabular labrum. And that labrum, like the meniscus in the knee, its major role is to deepen the articulation, so to create more room for this very round, large femoral head. But then in addition to that, you can see the acetabular labrum has kind of like a lip to it. And so it acts as a suction cup, creating more stability between the femoral head and the ilium of the pelvis, right? Now, as we move over to the pelvis side, the pelvis is comprised of the ilium on the right side, the ilium on the left, and the sacral bone, right? The ilium on each side will come together to articulate with the sacrum. You can see that here and there. And this joint we know as the sacroiliac joint, which is the articulation between the sacrum and the ilium on each side. As we move more inferior and anterior, we can see that the pelvis is also comprised of the pubic bone. Pubic bone is most anterior. Each pubic bone, both right and left, come together and articulate via the pubic symphysis, which is a disc, kind of like the meniscus in essence, which is going to prevent friction or rubbing across the two pubic bones as they come to meet in the anterior center of the human body. And then more posterior inferior, we have the ischial tuberosity, which is here. Now, this is an extremely important anatomical landmark because it proximally receives the hamstring muscle group, right? And so if we look at our gluteal folds, this palpation would be found just underneath the gluteal folds of most individuals. So we can see the reason that we really have pelvis and hip into combined lectures is because the hip articulates with the pelvis, and then we should just talk about the pelvis because it is an extension of the actual hip itself. Now, as we look at the pelvis, one of the things that we know about forces is the foot hits the ground. Forces are transmitted through the foot to the ankle, through the tibia, and then through the femur, right? Those forces are then transmitted through the femur, through the iliac fossa, and then eventually kind of hit the sacrum. And when they hit the sacrum, if they're centralized, then they'll move through the actual spinal column, right? And that's the ideal way that forces are supposed to move, through the actual sacrum or through the human body itself. So that sacrum is extremely important. It's kind of like the relay station or the pivotal point in which forces are going to be transmitted through the rest of the spinal column. So any disruption to the ilium or the hip joint, and we might indirectly see issues occurring in the lumbar spine. So we've talked a lot about the bony anatomy, and then we have to look at the dynamic structures that are responsible for kind of tying the pelvis to the hip to the pelvis, and the spine to the pelvis or the hip. And so I'll start proximally first. This is what we would say is the lumbar spine. So L1, L2, L3, L4, L5, and then what we have here is T12. So what we can see is that your psoas muscle is going to have a proximal attachment to T12. So this is one way that the pelvis is attached to the spine, right, via the psoas muscle. Now the psoas muscle, because it's a two-joint muscle, is going to aid in obviously stabilizing the abdominal cavity or thoracic cavity, or lumbar cavity. And then in addition to that, it is also a hip flexor, right? So it moves or drives hip flexion. There are two other muscles that are also responsible for driving hip flexion as well, and that's going to be this large muscle, two-joint muscle right here known as the sartorius, which is a major hip flexor, and then the largest muscle in the quadriceps, the rectus femoris. So we have these three muscles working to drive hip flexion moment. And then we have four muscles working to kind of help with knee extension, and that's going to be the rectus femoris. If we were to transect and reflect the rectus femoris away deep to that would be the vastus intermedius. On the lateral side, we're going to have the vastus lateralis and then vastus medialis on the medial side. Those muscles are going to help concentrically cause knee extension, or another way to say that is eccentrically, it's going to slow down the rate at which we move into a knee flexion moment. On the lateral side of the hip and pelvis, we have the tensor fascia lata, which proximally is a muscle. We just learned about the IT band, which is more connective tissue-like and will cause pain in the knee joint. So we can see that tensor fascia lata is a lateral muscle. So it's going to play a major role in hip abduction along with the sartorius, which also helps with hip abduction. And if we were to look over on this side of the image, another muscle that's going to be a major contributor to hip abduction is going to be that glute medius. Now, on the medial side of the limb, we have a large strap-like muscle known as the gracilis, and then we have our adductor muscles, the pectineus and the adductor muscles, which are all going to help with hip adduction, but will also help with internal rotation as well. Now, as we look posteriorly, we see a few different structures. First and foremost, this is the ischial tuberosity. If I were to go back a slide, I'm referring to this anatomical structure here, right? So let's move forward. As we look at that, we can see that the hamstring muscles, the biceps femoris, the semitendinosus, and the membranosus are all going to come up, become one tendon, and attach proximally to that ischial tuberosity. But other things that we notice in the posterior thigh is that we have this sciatic nerve. And this sciatic nerve sits or lives just deep to the piriformis, right? Piriformis, even though it's a small muscle, is a major hip external rotator along with a few of the other hip intrinsic muscles. But what we know about that is in a subset of patients, if it gets enlarged or if it contracts too much, it can impinge upon the sciatic nerve and cause sciatic neuropathy or signs and symptoms, which we will talk about in just a little while. All in all, we have a lot of major dynamic stabilizers at the hip, which is interesting, right? Because the hip has a lot of mobility, yet at the same time, we have anatomical structures in place, the labrum to create stability there. Then we also have lots of muscles that surround that hip and pelvis joint, making it a very stable joint as well. So this is just an in-depth look at the posterior kind of pelvis hip muscles. The glute maximus, which is the largest of the gluteal muscles, right, is a major hip extender. In addition to that, the hamstrings also secondarily assist at the hip and hip extension, but the major hip extender, is the glute maximus, right? And what I love about this image is you can really see the relationship between the gluteal muscles and then the intrinsic muscles of the hip. So the glute medius is, like the tensor fascia lata, a hip abductor. And depending on its fibrous orientation, can either assist with hip internal or external rotation. And then on this side, what we have is the glute minimus, which helps assist weakly with hip abduction. What I want to point out here is the piriformis. Piriformis is an external rotator, and then we also have smaller external rotators called the deep hip intrinsics. So the quadratus femoris, for example, the superior gemellus, those are all going to be deep hip intrinsics that also facilitate or assist with hip external rotation. If we were to take this a little bit deeper, and I don't know if this is beyond the depth of this class, but it gets me excited that you all want to learn and take your knowledge deeper. So I'm taking you there quickly. So we have the glute maximus, which has been transected and reflected away. And then we have the glute medius, which we already said is a hip abductor and can help with transverse plane motion as well. One of the muscles that I mentioned was the piriformis, right? Very small muscle, but contributes to hip external rotation. But just deep to that piriformis lives our sciatic nerve. And if we look at it from this perspective, the sciatic nerve branches into two very important nerves distally. So the tibial nerve, which will supply the posterior compartment of the lower limb, and then it branches off into the peroneal nerve. So you either will have the common peroneal nerve or the deep peroneal nerve, all which supply the anterior and lateral compartments, right? And so we can see that if we have a tight piriformis or a spasm piriformis, for example, that might actually cause sciatica, right? Might cause some signs and symptoms into the hamstring muscle or maybe even into the lower limb. So knowing anatomical orientation, knowing which muscles live where and which neurovascular structures also live where they live, oftentimes can help you in your assessment of patients with hip, thigh, pelvis pathologies. So if I could review the anatomy, we know that the hip is a very extremely stable joint, and that has to do with the acetabular labrum, deepening the articulation, creating that suction cup, right? And then all of those dynamic stabilizers, those muscles, right? Which all surround the joint and make it extremely stable. But it also requires a lot of flexibility, right? Or mobility. It's a joint that can move in multiple directions and has lots of degrees of motion. So it's one of those joints that has to be stable, but then also has a lot of mobility. Here is the deal with the hip joint. And one of the trickiest things with the hip joint, in my opinion, is that if the mobility of the hip, if there's a lack of mobility, for example, in the hip, what we typically see is that it can lead to low back pain issues. So I'm going to go back here really quick. I'm going to take it to this image. We said that the psoas muscle comes up and has an attachment to the thoracic spine, T-spine 12, but we can see that it also attaches to L1 through L2. So we can see automatically, like if we have a really tight hip flexor, how that might actually create some torsion at the lumbar spine and cause maybe some lumbar spine pain, which is why I make this bullet point here, which says we have to start thinking about the lumbopelvic hip complex, or think about the hip and the pelvis and the lumbar spine all together as a unit. And we call that the lumbopelvic hip complex. What that means is if we have compromise to the pelvis, or if we have compromise maybe to the hip, oftentimes it can lead to pain or lumbar spine dysfunction, right? And so when we have a patient who comes into us with low back pain, oftentimes we forget to look at the hip joint, or we forget to actually look at the muscles surrounding the hip joint as contributors, and we'll most often just stay really focused in on the lumbar spine. But oftentimes lumbar spine pain may actually be an indirect kind of hint that there's something else going on at the hip joint itself. So make sure that anytime you have a patient coming in with low back pain, that you assess hip function. And then also know that if you have a dysfunctional hip or a lack of mobility in the hip, that it may increase stressors at the lumbar spine, which may over time lead to low back pain in that particular patient, right? Now the hip joint, as I said, is a very mobile joint, has different ranges of motion. So in the sagittal plane, we have hip flexion and extension. The muscles that are going to be most responsible for hip flexion moment are going to be the psoas, the sartorius, and the rectus femoris, right? And we also move into hip extension, or bring the hip back, right? The muscles most responsible for that is going to be the glute maximus, and then all of the hamstring muscles, which have that proximal attachment to the ischial tuberosity. And we also know that the hip moves in transverse planes of motion, so internal, external rotation. Your external rotation moment is going to occur most often with the piriformis, and we could even say with the deep intrinsics. And then your internal rotation moment, that maybe glute minimus, for example, but I would even say internal rotation. Your adductors would also be responsible for those as well. And then we have hip adduction and abduction. Adductor muscles are going to be responsible for adduction. And then our abduction moment most often is going to happen with tensor fasciae lata, your glute medius. I would even throw sartorius into that group. So we can see all of these complex motions in sagittal, transverse, frontal plane. We can see that there's lots of mobility within the hip, right? Probably one of the most mobile joints in the body, minus the shoulder. Shoulder's definitely the least stable and most mobile joint that we have in the human body. So let's talk key pathologies. The first group of key pathologies are going to be any type of fracture or dislocation to the hip. And I'm going to talk more in detail about these on different slides. But the first one's a femur fracture. And when I say femur, what I'm referring to is a mid-shaft fracture. So that's a medical emergency anytime we identify that. What we can see in this image is the quadriceps are really tense, right? So they're really spasmed. And so the concern with a through and through femoral shaft fracture is that as those muscles start to tense up, they'll start to pull the fractured pieces across one another. And that's from a fractured shaft of the femur is pretty painful. Most often the patients will go into shock. In terms of treatment, most EMTs, paramedics will apply a traction splint. You have to actually be skilled in that and be trained in that, but they'll apply a traction splint, which will create a little bit of traction, cause the quadriceps muscles to kind of quiet down and keep those bones in the right position so that when they go into surgery, we don't have to kind of readjust or reset those bones. If you're in the clinic and you see a patient with a femoral mid-shaft fracture, then you can, if you don't or aren't trained to use a traction splint, then you certainly can just do a little bit of traction towards the tibia. Of course, not moving the limb too much. We always want to splint the limb as it lays. The next and most common type of hip fracture that we'll see is what we call a femoral neck fracture. So remember, if we were to skip a few slides and go back to that anatomy slide, remember this is where the femur is changing its shape. And so oftentimes we'll see that there will be a fracture to the actual femoral neck. So when I say femoral neck, this is the part of the femur that I'm most often referring to when I say femoral neck fracture. It's the most common in runners, and I'll talk about that on the next slide. A hip dislocation is most often a medical emergency, and most often when we see it, it's going to be a posterior dislocation. So that patient, as you can see on this table, will present with the hip and knee and a little bit of flexion. They'll be internally rotated. You see that angle here, and adducted, so the limb will fall towards the other limb. If you see something like this after maybe a blow to the hip, then you're thinking hip dislocation, medical emergency. All of the arterial and neurovascular bundles that are compromised during a hip dislocation make it extremely important to get the patient treated right away. And then, of course, you can have a pelvic fracture. So we see that here in this image. Most often we see that in elderly patients as they start to lose their proprioception and their balance or their sense of where they are. Patients over the age of 55 tend to slip and fall more and will fracture the pelvis. So let's talk femoral stress fractures. You can have two. You can either have a shaft stress fracture, you can have a femoral neck stress fracture. Most often, though, each of these types of fractures are going to be associated with repetitive running and jumping activities, in particular as you're running downhill. I've really only ever seen femoral stress fractures in the shaft and in the neck, honestly, in runners and gymnasts most often, and in female. And so that is what the research actually suggests, is that most of these types of fractures happen most often in women, in particular women with some sort of maybe disordered eating or malnutrition oftentimes, but it certainly could just be a female runner who's putting lots of miles on her body, and as a result, the result is what you see here, a fracturing of the actual femoral shaft itself. So what are the signs and symptoms? One of the differentials that we see in terms of femoral neck fractures is that patient is going to report like a deep-seated kind of hip pain or groin pain. And oftentimes as clinicians we'll say, oh, well, your groin is strong. You don't really have any issues with strength, right? And so we'll oftentimes kind of blow it off. So anytime you have a runner that's a female that is distance runner in particular, if they present with a deep-seated groin pain and their strength is pretty high, one of the things you want to do is refer out and make sure you're not missing a femoral neck fracture. So that would be a differential, getting that x-ray to make sure. But we know, you all know, because you guys are amazing clinicians now, that the number one sign and symptom, one of the number one signs and symptoms of a patient with a stress fracture or fracture really is the night pain. It's going to wake them up at night. They're not going to be able to sleep. Of course, we'll do the HOP test, which you all have already done in class, and then the torque test, right? And if any of these are positive, then we're going to refer out and hopefully get some type of radiologic imaging to confirm your assessment. Now, I most often try not to treat all images conservatively, but there are times where pathologies come around that weren't being treated conservatively, and the first one is a femoral a femoral neck or femoral stress fracture. So typically we'll have them rest for 2 to 5 months because it's such a large weight-bearing bone that the only way to allow it to heal and for it to not become a repeat stress fracture is through rest. So what we can do with them is they can swim, they can elliptical, they can treadmill, they can do maybe some grass running, which is really low impact. The goal is ultimately that we want to reduce the amount of impact traveling through the actual femur itself. Next on the list is a hip pointer or a pelvis contusion. So we have the ilium itself, and then we have this thing called the iliac crest. It's the thing that's anatomical structure that's most palpable to us. The mechanism of injury is going to be blunt trauma. I mean, I don't know if you're as clumsy as me, but I feel like I have a hip pointer every other month because I keep bumping my hip on this specific point on my couch, right? So blunt force trauma. We see this oftentimes. We can see it in like soccer, for example, if they're slide tackling. But so it just depends. In a sport where there's lots of bumping or contact to the iliac crest, it can be extremely, extremely painful. We can see here, this is probably like a grade 2 plus maybe 3 contusion, lots of bleeding, lots of damage. So palpable pain, most certainly on the iliac crest itself. They're probably going to have lots of ecchymosis. That's because we have a lot of dynamic structures or muscles that are rich in blood. So you're going to see the ecchymosis or the bleeding that's going to occur. And then what we typically say is if we ask a patient to move into certain ranges of motion, it's going to aggravate it. So like adduction will aggravate it because it's going to stretch, right? Abduction may aggravate it because guess what it's going to do? Cause hip contraction and use those muscles. So we want to be cognizant of that. In terms of the treatment, it's really going to depend on the severity, right? Oftentimes, if they have full range of motion, if their functional capacity isn't limited, then we return them to play and maybe we put a pad there to protect them, right? But for severe contusions like this, the odds of them being able to return to play functionally without a lack or a limit in range of motion is very slim. So we typically will put them on crutches, might do some ice, maybe some soft tissue later on to relieve the pain that's associated with that. We might give them some anti-inflammatories, but we really want to conservatively manage this until it heals. Scary thing about bone contusions, and oftentimes some people are like, I wish I would rather have a fracture, is that it can take up to 6 months to heal. And what's that mean? It doesn't mean they can't play for 6 months. It just means that the patient might actually be in pain for 6 months. So if this is the case where you have a patient who presents with a lot of ecchymosis, limitations in range of motion, we can always refer out for an x-ray to rule out fracture, especially if they're reporting night pain, difficulty sleeping, not like just sleeping on that side, but true difficulty sleeping. Next up are hamstring strains, probably my least favorite pathology to treat in the clinical setting, especially if they are a runner or a hurdler and it's their lead leg. Hamstring strains are most often caused by excessive loading in the eccentric phase, so like the terminal phase of gait, because the muscle is kind of like at its most stretched component and moving into its shortened component, and so as a result the muscle fails. But it certainly could happen as a result of like an excessive hypercontraction, but most often we see it like in its stretched phase. This image here, oh man, that's a beautiful hamstring strain, right? It represents what a hamstring strain might present like. Here's the scary part about this. Not every hamstring strain is going to present like this. It's going to depend on the grade. It's going to depend on the amount of tearing or tissue disruption in that particular injury. So this is just one image, but you certainly can have patients come into your clinic who have hamstring strains and do not have any sort of ecchymosis. So let this be one objective assessment, but not the one that you would use to diagnose whether or not a patient has a hamstring strain. So often the patient's going to have an antalgic gait. What that means is it's altered and it's usually painful. Most often you'll see that they'll shorten their stride because having a longer stride will stretch the hamstring muscle and cause more pain. Definitely going to be that tender to palpation in the area, limited in range of motion, in particular into knee flexion moments. And then depending on the severity, their strength is going to be impacted, right? So what do we do for them? Regardless of the degree or severity of the strain, typically it's 2 to 4 weeks before returning to play, because what we know about this window is that the chance of re-injury is relatively high if we return them anytime before then. And that's because we have what we know about running and hurdling is that it's going to place that muscle on a stretch. And so we need to work on it. And most often working on it typically includes doing lots of eccentric training with the hamstring muscle group. And I'll show you what that looks like in class so you can get a feel for what it's supposed to look like. Groin strains most often happen when the hip is placed in an external rotation moment. Remember, those adductors assist or get shortened when we're in internal rotation. So any external rotation moment or extreme hip abduction moment, and we're going to stretch the groin and cause some pain. Now, the scary thing about the groin muscles, and we can kind of see them here, these are the traditional groin muscles over here, but we have that pectineus, which sits very anterior, right? Is that they attach to the pubic bone. We can see that they're in different iterations of this, right? And so when we have a strain, if the force is great enough, in particular, if the abduction is great enough, what you can see is, remember, if we were going back to that anatomy slide, we would see both pubic bones coming together. We would see that pubic symphysis sitting in the middle. So if that force is great enough to cause some type of groin strain, most often it disrupts the pubic symphysis or the two pubic bones where they articulate. And so that patient will have pain most definitely on the inside of the thigh, but then may also have pain in the pubic region, right? So what are some signs and symptoms or objective findings? They will most often report some type of pop, and they'll have pain with active contraction, which would be adduction, and then passive stretch, which would be hip abduction, right? So what do we do for these patients? We're going to strengthen. We're going to do both concentric and eccentric exercise. Again, like hamstrings, treating them very conservatively. We're going to delay exercise until they're pain-free. And then lots of rest ice compression, NSAIDs in the acute and anti-inflammatory phase. Now, a fun syndrome, which is pretty rare, is known as snapping hip syndrome, most often caused by tightening of, it could be one of two muscles. So it can be the iliopsoas, which is known as internal snapping hip syndrome, or it could be the IT band, which is known as external snapping hip syndrome. And if you have a hard time remembering which one's internal, external, think about where they insert. This inserts more laterally, right? And this we see attaches to T12, comes down and has an attachment onto kind of that lesser trochanter. So it's more internal. Either way that we look at this, one of the things that we see is when they move into hip flexion abduction moments, the patient will report that they feel either the iliopsoas snapping over, or they feel that IT band snapping over the greater trochanter or lesser trochanter. So they'll feel like a snapping or a popping either internally or externally. If it's external snapping hip syndrome, you'll feel it as they move into hip abduction flexion moments. You'll feel the IT band snap forcefully over that greater trochanter. The hard part with this pathology is every time they move into those motions, that snapping will cause an irritation. And so they'll start to have pain when they're participating or when they move into certain degrees of hip flexion abduction moments. And so they'll want to avoid that. And so objectively, what we'll see observation-wise is they might shorten their gait or not move into as much abduction, not move into as much hip flexion moment to avoid the snapping that will occur. But typically, it's limited hip flexion and extension, and you'll see the snapping most often. So what do we do for them? We're going to limit painful motion. And then the biggest thing is most often it's a tight muscle that's causing that. So we're going to try to lengthen that. We're going to try to massage that. We're going to stretch that, foam roll it, really work on flexibility of those two muscles. So again, you can see it here. If it's an external form, it's going to snap across the greater trochanter. You can kind of see that there. And then if it's an internal iliopsoas snapping hip syndrome, you'll see it snap over that lesser trochanter most often. Now, glute med weakness. We go back to lumbopelvic hip complex, where we talked a lot about if there are dysfunctions at the hip and the pelvis, then oftentimes that may play a role in the low back pain that a patient is experiencing. So I wanted you to see this because what we know about the glutes is they play such a critical role in lower extremity biomechanics. In other words, the major role of the glute medius really is to stabilize this hip on the pelvis, right? And so it is responsible for making sure that the pelvis is level in essence, say it that way. And when the pelvis is unlevel, we can see how the shearing forces kind of go across L5 and L4. So really making sure that those glutes are strong so that the shearing forces are decreased. And remember, we talked about the sacrum being that kind of relay station where it's going to take the forces and distribute them up the spinal column. So any weakness to those glutes, then we might have, what's the right word? We might have an imbalance in the load across the pelvis and the hip, which will then make forces get generated, or the central focus of forces occur at the L4, L5 or L3, L4 lumbar junction. So overall, weaknesses and imbalances, they can impact the lumbar spine. But the other thing that we see is that a weak glute med may also cause knee valgus, an increase in knee valgus angle. If we have a weak glute med, which obviously changes the way in which the hip is sitting on the pelvis and causes more angulation into a knee valgus moment, what injury are you thinking that they might actually suffer from or be at risk from? I'll say it that way. What injury do you think they'd be at risk from? Write it down and tell me. And yes, the answer, if you said ACL, you would be 100% correct, right? So one of the things that we do with female sports in particular is assess glute med weakness by having them walk. Most often they'll have what we call is a Trendelenburg's gait, where you kind of get that hip shifting as you walk. And if we see that, then we automatically start to strengthen the glute med so that we have less risk of suffering from, guess what, an ACL rupture. Certainly more shearing forces across the lumbar spine. And so in that regard, you could have a patient with an ACL rupture and chronic low back pain as a result. Now, I'm a nerd and I like to read literature. One of the things that has come out in the last 5 years is that the glute med has been, a weak glute med has actually been linked to increased risk of inversion ankle sprains, right? It's kind of scary. And so what you might think is, oh, just an ankle sprain coming into you because they inverted forcefully. I always look at, okay, did they have a weak glute med, right? Because you've got this valgus moment at the knee and now maybe increased risk for ankle sprains. So we want to be careful. Again, it goes back to the hip not getting a lot of credit for some of the things that happen throughout the body. Lumbopelvic hip complex. If the hip, for whatever reason, is unstable, i.e. maybe the glute med isn't stabilizing it on the pelvis, well, we just said we're going to have increased valgus angle, which may increase the risk for ACL injury. We're going to have increased valgus angle. We're going to have a shift in the Q angle, which might increase the pain they're reporting at the lumbar spine. And then what we also know about lateral ankle sprain patients is they have a weak or inhibited glute med. So there's lots of evidence in the literature to suggest that we need to make sure that if there's one muscle that is strengthened and strong, it's the glute med, because we can reduce a lot of effects, right? We can reduce maybe the incidence of low back pain. We can reduce the risk of ACL ruptures and or lateral ankle sprains. Now, here is piriformis syndrome. We talked a little bit about the piriformis muscle in the anatomy slide, but what we're really seeing here is the intimate relationship between the sciatic nerve, which lives just deep to that piriformis. So here's the piriformis, just deep to that is the sciatic nerve. And then we also have another muscle which sandwiches it, known as the obturator internus, right? So that sciatic nerve sits in between the two. The muscle that has been reported to cause sciatica, if the sciatica isn't coming from the lumbar spine, has been the piriformis syndrome, piriformis. So what happens most often is the piriformis is extremely tight and contracted. And so when it's contracted, it will apply a downward pressure to the sciatic nerve, causing sciatica, right? So the mechanism of injury most often is going to be like spasm or tightening. However, there is a small subset of patients who are congenitally born with the sciatic nerve piercing through the piriformis. Can you imagine that? Where every time the piriformis contracted, it squeezed the sciatic nerve, causing sciatica, right? So in terms of signs and symptoms, it's going to be pain or tightness in the gluteal region. But what you'll typically see is they'll complain of some type of neurological signs and symptoms, so radiating pain, etc., into the hamstring muscle group. If the tightness and or the compression of the sciatic nerve is great enough, it could certainly go into the lower leg, right? Because we can see that image where that sciatic nerve branches into tibial and common deep peroneal. And so it certainly could go into the lower limb of the patient. So what do we look for? We most often will look at whether or not the patient has atrophied gluteus medius, right? That would be a big sign and symptom. Limited range of motion. So it's an external rotator. So anytime we externally rotate, if it contracts, it's going to compress on the sciatic nerve, causing more pain. So they'll be apprehensive in moving into an external rotation moment. And we can also use the Piriformis test, which I'll show you in class. So what do? We're going to stretch that piriformis, so take it into an internal rotation moment and hopefully stretch it and increase flexibility so it's not as contracted. Lots of foam rolling, lots of elbow into the patient's glute to cause maybe like a active release of the piriformis, and then correct any muscular imbalances, which I'm going to go back here. And really what we're referring to is, okay, is the glute med doing what it's supposed to do, right? Is it taking some of the pressure and the load off of the actual piriformis? But yes, we want to strengthen any muscular imbalances that we see. That can include a glute medius that needs to be strengthened because it's currently atrophied, right? Next is hip impingement. We can have impingement of the hip, which occurs via a pincer or a cam impingement, and they get their name based on their actual deformity. So a pincer deformity is one in which there is an exostosis or bony growth on the actual acetabulum itself. So the acetabulum is the reason that the patient is experiencing impingement. So example, when we abduct and or flex, guess what's going to happen? That pincer deformity is going to impinge the muscles and the ligaments during flexion and abduction of the hip. On the opposite side of that, we can have a cam impingement. So a cam impingement is a deformity of the actual femoral head and the neck. So in other words, the bony growth occurs on the femur itself. And the same thing is going to happen, right? You get compression of the muscles. It's just a matter of where that compression is actually occurring, right? With the pincer, the compression is occurring because we have a deformity or a bony outgrowth of the acetabulum. With the cam impingement, the compression is occurring because the deformity is occurring on the femoral neck and or the femoral head. What this does is anytime that patient flexes or extends the hip or abducts the hip for that matter, they feel a deep-seated pain because those dynamic stabilizers, those muscles are getting impinged against that bony outgrowth, and it can be very debilitating. Oftentimes patients will actually have to go into surgery to kind of have either their acetabulum reshaped or their femoral head reshaped. Next is a labral tear. As I mentioned, the labrum is an extension of the acetabulum. It also lives within the acetabulum. It's going to deepen the articulation, right, and allow that head to kind of sit within the acetabulum itself. But it can become fractured. Most often it will become fractured, particularly the rim of the labrum will become fractured during some type of dislocation or subluxation or repeated subluxations, right? So that's most often when we see it. We can also see a lot of times if there's a hyperabduction or hyperextension moment, the labrum can become disrupted. The problem with the labrum when it becomes disrupted is it does what? Tell me what you think it does. If it creates stability, if we have a fracture, there's more movement, even more mobility than we would expect within the hip. And so again, that goes back to the lumbopelvic hip complex. If the femoral head is allowed to move more within the actual acetabulum, those forces get transmitted differently through the sacrum, right? Causing maybe some low back pain that wouldn't have existed if we had a more stable head within the acetabulum itself. So signs and symptoms of a labral tear are very similar to meniscal tears. So they're going to complain of clicking and popping, a deep-seated hip pain. The hip may lock depending on, remember, the type of tear, if it's a flap tear or not. And the hard part with this is it's deep-seated hip pain, right? I've already talked about at least one pathology that's going to present like deep-seated hip pain, and that is a femoral neck fracture. A muscle such as the pectineus or the adductors can also present with deep-seated hip pain, but they won't be able to pinpoint the location because the reality is, depending on the type of the tear, they may feel like their entire hip hurts, right? So what are the signs and symptoms that can help us kind of determine and create differentials? The clicking and the popping through the range of motion would be one, although One of the things we know is that snapping hip syndrome does that. We also know that snapping hip syndrome only occurs during certain motions. The other thing that we can do is we can load the labrum. We can load the labrum with a hip scouring test and do a grinding of the labrum to see exactly where the pain is. So oftentimes labral tears are often overlooked because, again, they're usually misdiagnosed as a muscle pathology, right? So anytime you have a deep-seated hip pain, just refer out to make sure, because here's what happens. If the labrum is torn, remember, it also prevents the femoral head from rubbing up against the bony acetabulum. So if we have tears in the labrum, then oftentimes, if it goes undiagnosed for years, that patient develops osteoarthritis, right? Where we actually start to see the wearing away of bone, and then they're in constant pain and might need a hip replacement. So if we do encounter a labral tear, most often surgical intervention is required. So they'll go in and they'll repair that labrum. And it is a lengthy rehab program, anywhere from 8 months to a year to recover, with a increased risk for re-injury because most of these patients are in high impact sports and because the hip is just a mobile structure. Next, we have osteitis pubis. Remember I said the pubic bones come together anteriorly, and then we have this disc right here known as the pubic symphysis. So in sports where there's repetitive adduction moments, and we can think of a few, right? I'm thinking of gymnastics, for example. I'm thinking of dance. I'm thinking of cheer, where you might be going into the splits very often, where there's these repetitive stressors on the pubic symphysis. Then that patient will start to develop like a chronic pain and inflammatory process within the groin or anterior pubic region. That patient's going to be tension on the actual pubic tubercle, which is going to be the most anterior portion of the pelvis. So what do we do for them, right? Really rest NSAIDs and avoid abduction moments as much as is possible, and then a slow, gradual return to play, particularly if they're gymnasts and or soccer players. Next up is athletic pubalgia, or the sports hernia. It can occur secondary to repetitive stress at the pubic symphysis. Most often it's also associated with a forced adduction moment. So what is a sports hernia? Like, what is it? So micro tears of the rectus abdominis. It can also be tearing of the hip adductor or the oblique muscles. And y'all might say, like, how is that different than a traditional hernia, right? And I actually think that would be a very valid question, right? Because we can have patients who suffer from what we call is the traditional kind of inguinal hernia. And then we also have what we call as athletic pubalgia, or a sports hernia. So sports hernias are going to present very similarly to an inguinal hernia. The major differential, I think, is an inguinal hernia is most often limited to an injury to the abdominal cavity, but the difference is typically some sort of abdominal tissue, most often the intestines, will protrude through that weak spot, particularly in the inguinal canal. Whereas a sports hernia is most often occurs to actual muscle. There isn't any protrusion of the intestines through any of the muscles that might be injured during a sports hernia. And so those are the differentials, right? Signs and symptoms: chronic, sharp, burning pain that radiates into the adductor region. And then we can also see that they might have pain at the pubic tubercle, right? So what do we do to see if it's a sports hernia? They're most often going to have pain with resisted hip flexion, adduction, internal rotation, and a crunch. So imagine having them lift up the injured side of their leg, flex the hip, adduct, internally rotate, and crunch all at the same time. That's a differential, right? That's going to be a lot different than osteitis pubis, right? Which is really, it's more so pain, tenderness to pain on that adductor tubercle. They may or may not have pain with adduction. But again, if we go back here and we're trying to decide between the two, biggest difference is when we do a resisted sit-up with hip flexion, adduction, internal rotation, that is going to light them up. So what do we do for these individuals? We're going to conservatively treat them. We're going to work on strengthening all of the core, so our abs, our hip flexors, our adductors. Some physicians do aggressive treatment. So in other words, they might do a cortisone injection, or they might just go in and suture the muscle where it's actually herniated. And if they do that, then oftentimes it's going to take about 6 to 10 months to kind of heal themselves. So very slow process. But major difference is inguinal. There's some type of abdominal tissue, most often the kind of intestines, which will protrude through. And in athletic pubalgia, the muscle is most often injured, and we have pain with that resisted hip flexion, adduction, internal rotation, crunch moment. Now, we've talked a lot about bursa. We know that bursa are almost like water sacs essentially, which help reduce friction at increased friction sites. So in the hip, we have bursa called the trochanteric bursa. And this bursa lives between the greater trochanter and kind of that tensor fascial IT band junction. Now, we had a pathology, and that pathology was called external snapping hip syndrome, right? Most often caused by the IT band, usually during flexion extension moments where it's snapping over that greater trochanter, right? Sometimes before we develop snapping hip syndrome, we might develop a bursitis. If there's just repetitive kind of snapping of that muscle structure over the greater trochanter, the bursa might get inflamed and cause a lot of pain in that particular area, right? We can call this IT band friction syndrome on the proximal side of the hip. In terms of signs and symptoms, the key sign and symptom is tenderness palpation right on that lateral protrusion or the greater trochanter. And so what do we do for them? A couple of different things. Your textbook said rice and NSAIDs, but that typically doesn't work. So they'll go in and kind of do a cortisone injection into that area. And then you want to look at different biomechanics, what things might be increasing the angle, right? The Q angle, for example. And we want to correct those wherever we can. Also look at the glute medius, right? A weak glute medius might cause the pelvis to tilt, which would cause more stretching of the IT band, which might cause more snapping. So as we fix the problem, the thing that we want to look at are the biomechanical differences that might actually be present or might actually exist. Okay, our last category of pathologies are pathologies where there's a lack of blood supply to either the neck or the head of the femur. Again, most oftentimes happens in adolescent patients, but certainly can occur. Avascular, the name implies, no blood, necrosis meaning death. So we have some type of pathology to the femoral head and or acetabulum or neck where there is a lack of blood supply to this proximal femur or proximal structure. In the early stages, there may not be any signs and symptoms. In fact, you really won't start to see signs and symptoms until the femoral head starts to flatten out or become deformed, because then at that point in time, what you'll start to see is the femoral head doesn't move in the acetabulum like it's supposed to. But as the disease progresses, essentially what we start to see is that patient will have lots of pain during weight bearing, right? Because during weight bearing, that head is sitting in the acetabulum, and so there's movement that occurs, and so there's a grinding of that head, that flattened head, which will elicit or cause pain. So if we could look at avascular necrosis on a spectrum, we would say there's some type of disruption in the blood supply that can be traumatic, like a hip dislocation, or we could just have patients who were born that way. So oftentimes during a breech birth, where the physician or the nurse practitioner or the PA or the midwife is maybe pulling the baby by their limbs, right? You might get a tractional force on those arteries that are supplying the head, and that in of itself might cause damage to the arteries and cause a lack of blood supply. So you have trauma, direct blow. You can have indirect, non-traumatic way. But the femoral head, what happens is the bone cells start to die. You can kind of see that there. And then what it does is it changes the shape of the femoral head. So what do we do for these patients? X-ray, MR, CAT scan. Most often surgery is required to kind of shave down and maybe even to restore blood flow. And then we want to be non-weight bearing if possible. So these two pathologies, the first one is called Legg-Calvé-Perthes disease, say that a few times, is avascular necrosis of the femoral head. So this is direct, meaning that the femoral head isn't receiving enough blood supply. Most often, again, usually seen in kids between the ages of 4 to 10. We'll just say adolescent. 75% are non-traumatic, and the other 25% of the cases are traumatic. So what I'm saying to you all is you're most often going to see the non-traumatic cases that come on as they get older, right? The articular cartilage, which is the femoral head, becomes necrotic and it starts to flatten out. So you can see that here. And so you see in this beautiful image, that femoral head is sitting in the acetabulum. You can see here, there's this flattened head that doesn't fit in here. So in essence, we kind of create kind of a cam deformity, right? Where you start to have the head that doesn't fit and it may start to actually impinge. So the signs and symptoms are going to be groin pain and limping, right? Which, oh man, that could be anything. That could be a femoral neck fracture, right? That could be some type of adductor pathology. So ultimately what we have to do is refer them out, right? And we refer them out, they'll get imaging. The imaging might look like this. And so then they'll brace them. Sometimes what we see in really young kids who aren't very active right away is they'll put them in almost in an abduction brace. So they'll put the limbs in abduction to force the head into the acetabulum and take on the shape of the acetabulum. So some type of bracing most often. Next, we have slipped capital femoral epiphysis. This happens most often in boys between the ages of 10 and 17. And so what we see here is the head starts to slip away from the neck, right? So we can see the head sitting here and then the neck is kind of displaced, right? So this is actual not death, but a slippage of, which could lead to death over time, especially if arteries become entrapped between the head and the actual neck itself. And so the signs and symptoms are very similar. There's pain in the groin, they're going to be limping, but the major differential is they'll have a limited range of motion in abduction. That would make sense because there's going to be like this impingement or this bony block, flexion, and maybe rotational moments. And so we can try a scouring test. If the scouring test is positive, we're going to refer it out anyways because we oftentimes think of a positive scouring test as being associated with a labral pathology. So what do we want to do for these patients? Rest and non-weight bear to unload. But ultimately, depending on the grade of the slippage, the physician will go in, reposition the neck, and they'll do what we call is an internal fixation, where they'll put some type of screw in the neck and the head to kind of bring them back together. All right, I think this is our last slide, and I saved it for last. It's the sacroiliac joint. Remember, I talked about this already. It's the point at which the ilium and on the right and left sides come together to meet the actual sacrum itself. It creates the sacroiliac joint. It's a major pain generator for patients who present to us with low back pain. The mechanism of injury, it really just depends. In females, especially postpartum, it's the laxity of the ligaments as the body has just been spread and now it's trying to come back to its together. So you get this laxity, and so you get shearing across the sacrum and the ilium, which again rediverts the way that the forces should travel through the spinal column. You can also have muscles, right? If we were to go back a few slides, you could have muscles, tight muscles pulling. I love this image here because it shows that there are at least 12 different muscles, right? Maybe even more than that are tugging and pulling in different directions, right? You can see here, you have your adductor muscles exerting a force, right? You're going to have your quadriceps or your abdominal muscles exerting a force, right? So we can see all of these muscles are going to act in some way on the pelvis. So anytime we have tight muscles, we get shearing forces across the sacroiliac joint. And then last but not least, the other way that we see sacroiliac joint pathologies is with leg discrepancies. So we have a long leg and a short leg. Typically that long leg is jarring the sacroiliac joint and will cause pain. So what are some of the signs and symptoms of sacroiliac joint dysfunction? And they might have pain in the gluteal region, but the research actually suggests 90% of patients who have SI joint pathologies report pain in the posterior superior iliac sacral region, and I'll show that to you in class. They'll also have pain with sitting. So they'll have a positive, what we call is Patrick Faber's test, and so pressing down on the knee here, pressing down on the pelvis here, and they'll have pain typically on that same side. So what are we going to do for them based on this image here? Lots of core stability, which will include abdominal work, which will also include hip musculature work as well. And I've seen some chiropractors, for example, manipulate the SI joint and use manual therapy. That concludes this lecture for the hip and the thigh and the pelvis pathologies. Looking forward to seeing you all in class.